all the doctors, ladies and gentlemen, and celebrities from the medical world gathered in this virtual platform to discuss about non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. On the behalf of Natco Pharma Limited, I, Shahid, most graciously welcome you and wish to thank each one of you for your esteemed presence at this webinar. Yes, it's an honor because we feel privileged to be amongst the faculty who have attained great name, fame, and success through their path-breaking work in their realm on non-alcoholic fatty liver disease, on which this evening is dedicated. At Natco Pharma, always we try to bring specialty medicine in India at affordable price, and we did it on hepatitis C and B products, many antibiotics, oncology, and as well as on cardio and diabetic products. And it's a great pride and honor to welcome the renowned chairpersons. Uh, Dr. Kadu sir is just going to join, and I welcome Dr. Deepti Chand, ma'am, Secretary of API Vidarbha chapter, and ma'am is associated with Government Medical College and Hospital, Nagpur. And I also welcome all the delegates. And now I am handing over the session to Dr. Shrikant Mukewar, sir.
Since Dr. Kadu is yet to join, I welcome you all. A very good evening and a belated happy Diwali to all of you all. I welcome you all on behalf of the Associations of Physicians of India and Dr. Mukewar's Midas Institute of Gastroenterology. It has been a privilege to hold this webinar along with Dr. Mukewar's institute, and he himself, along with the junior Dr. Mukewar, who's now eminent gastroenterologist at Cornell University, New York, is going to be the speakers for today, along with the Dr. Ambulkar, who's the head of the endocrinology department at Super Speciality Hospital, and Dr. Raj Gajbhye, head of the Department of Surgery, who's an eminent bariatric surgeon. So I welcome all the eminent speakers, and the moderator for today's function would be Dr. Sharad Deshmukh sir. He's a senior physician in the town and a very honorable figure around over here. So I welcome you all, and I now hand over to Dr. Mukewar sir for introducing about this program, how he conceived and how he's going to carry it on. So Mukewar sir, please.
Thank you, Deepti. A warm welcome on behalf of Midas Medical Foundation. And it's a joint venture between API and Midas. And I'm thankful to API for giving us the opportunity to discuss a very common problem, a very problem which is associated with a lot of new things. So I'm going to highlight about what is new in NAFLD in my lecture. And I'm so thankful to Dr. Sharad Deshmukh, Dr. Sunil Ambulkar, Dr. Raj Gajbhye, Dr. Saurabh Mukewar for joining in this symposia in spite of Sunday being a holiday. So I'm really thankful to them for sparing so much amount of time. You know, the program was earlier scheduled before Diwali, but for credit points, we had to postpone it after the Diwali. So ultimately, it was good that we could get a credit points from MMC. So I'm sure that this program is going to help in patient management and learning what is new and what should be done for a patient with NAFLD. With this, I hand over the mic to Dr. Sharad Deshmukh for further proceedings. You have to unmute. Sharad. Sharad. You unmute yourself.
Audible, yeah.
Now.
Yes.
Am I audible now? Am I audible? Hello?
Yes, you are audible. Go ahead.
Good evening, ladies and gentlemen. It's a great evening today. Despite the fact that this is a Sunday evening, I have been able to meet most of you, which is very difficult these days to see each other because of the ongoing pandemic. And let me thank the API Vidarbha chapter, Dr. Mrs. Chand and Dr. Kadu, the office bearers of API Vidarbha chapter, and Midas and Dr. Mukewar, especially from Midas Institute of Gastroenterology, for asking me to kind of moderate this very important session. Now, just to introduce what we are going to discuss today, now, let me tell you that when we were doing our MDs in medicine, so that was the time when this entity, particular entity of fatty liver disease, that time we used to call this, was not given a very great importance because it was always considered as a benign disease without much of consequences. But over a period of time, we have learned that it is not such a benign disorder, and it is known to progress and can result in chronic liver disease and even cirrhosis of liver and even malignancy. And that has raised the importance of this disease, and people started investigating as to what can be done for these people. And a lot of research has been done on this particular topic. And even for that matter, the researchers from India, especially from PGI Chandigarh, have also contributed greatly towards the development of the ideas in the management of the NAFLD. Now, the importance of this disease lies in the fact that large number of people, its prevalence is very high. In any society, whether you take Europe, European society, or Asian society, or America, the overall prevalence of this disease is more than 25% of the adult population, and that makes lots of patients. And there is in general, a rule of 25%, that there are about 25% is the prevalence in adult population, out of which approximately 25% of them, they tend to develop the NASH, or non-alcoholic steatohepatitis. And out of these NASH patients, about 25% of them, that means still a large number, can develop cirrhosis of liver. And so it is a heterogeneous disorder, and with a very wide spectrum, starting from just simple steatosis to NASH, to development of cirrhosis of liver, and sometimes even, unfortunately, hepatic cancer. So we have lots of discussions now coming up with Dr. Shrikant Mukewar to open up the innings, and he's going to speak on what is new in NASH and how to manage this disorder. So I'll request Dr. Shrikant Mukewar to go ahead with his talk. Thank you.
Yes. Thank you, Sharath, for this kind introduction to the topic. That will be better. What is NASH by definition? Take a minute, let me, the video pictures are overlapping on my slides. Better. By definition, you have to satisfy two important things. 5% of the liver cells will be occupied by fat, which is either demonstrated by imaging or histology. That's number one. So 5%. Second, you rule out secondary causes of fat accumulation, and amongst them, the commonest is alcohol. The second is steatogenic medications, and third are hereditary disorders, which are not common in practice. The common in practice are alcohol and steatogenic medications. Now, how would you exclude the other causes of steatosis? The most important is exclude alcohol. Hepatitis C is associated also with fat accumulation, so also Wilson disease. Prolonged starvation, parenteral nutrition are also associated with fat accumulation in the liver. Of course, the hereditary disorders like inborn error of metabolism, lipodystrophy, they are not very common in practice. Same is true about pregnancy-related fatty liver like acute fatty liver or HELP syndrome or Ray's syndrome. They are not very common in clinical practice. The most important are three things I would say: alcohol, hepatitis C, and medications. And medications, amongst medications, amiodarone, methotrexate, tamoxifen, steroids, valproate, and the ART medications are the ones which are very important. And you have to take history of in our hepatology conferences, the picture is shown of a white liver and what cardiac condition causes. It's an amiodarone which causes the white liver. What I'm going to tell you is prevalence. Now, there is a new entity. The name has been changed into NAFLD. We see that. I'm going to discuss then lean NASH. I'm also going to discuss what is the natural history of NAFLD. What are the clinical predator of NASH in NAFLD? Diagnosing NASH in NAFLD is important. NASH, as Sharad has said, that accumulation of fat in the liver without inflammation is NAFLD. But when there is a ballooning of cells, inflammatory cell accumulation, fibrosis, it is defined as NASH. Inflammation is there. How to diagnose, whom to treat, and how to manage will be discussed. Now, the first question. Normally, the concept of alcohol being beneficial in small amount, like the cardiologist always prescribes a glass of wine for their patients. And if the patient has NAFLD, the question is asked by many patients that can I have a glass of wine? So, and earlier there was a concept that small amount of alcohol consumption is beneficial in patients with NAFLD. So, what is a risky alcohol consumption? When would you say that this patient has alcoholic liver disease? When the patient, when in men you take more than 2 drinks per day and women more than 1 drink per day. So how much is 1 drink? 1 drink is equivalent to 45 ml of spirit. You multiply by 3, 120 ml of wine, and multiply by 3, 360 or 350 ml of beer. So that is defined as 1 drink. So if you take 90 ml, 1.5, more than 1.5 peg of whiskey, it is supposed to be risky alcohol consumption. Now, I was telling you advice regarding alcohol use by individuals with non-alcoholic fatty liver disease. This is a recent paper published in Hepatology, Korean study where light and moderate alcohol consumption to the tune of 7 grams per day, which is less than 1 unit. 1 unit of alcohol was 10 grams. That was associated significantly more likely to transit from low to high risk of fibrosis as compared to non-drinkers. And this study was done over more than 50,000 people, and the parameters used were, liver function test, the MR spectroscopy, the PDFF, which are the investigations for judging the fibrosis, and MR spectroscopy to find out about fibrosis. So the conclusion of this study is alcohol consumption is harmful in patients with NAFLD, even in small amount. So the answer for the question whether I can take one glass of wine is strictly no. What is the prevalence in Asian countries? Now, it is said that about, as Sharad had said, a formula of 25%, you can say that 25 to 30% of Indian population will have NASH, which will have NAFLD, and that depends upon various the investigative modalities. Normally, ultrasound is used as a modality, but because of the Western diet, sedentary habit, urbanization, metabolic syndrome, and obesity, the prevalence of NASH is increasing, and I would say that there is an epidemic of NASH in patients, NAFLD and NASH in Asian countries. Is it a new nomenclature, NAFLD? NAFLD has been very recently published in Gastroenterology 2020 that this entity of NASH or NAFLD should be having a new nomenclature of MAFLD. MAFLD is metabolic associated fatty liver disease, a consensus-driven proposed nomenclature for a non-alcoholic fatty liver disease. Why this nomenclature? Because this is a positive term diagnosed not only by exclusion of alcohol, but inclusion of metabolic factors. Definite abnormalities of metabolism are included, like obesity, diabetes, and other factors which you're going to say. And the alcohol intake in this, they say that more than 3 drinks a day would exclude that person. Secondary causes of fat deposition is replaced by alternative causes. So there's still controversy going on whether they should be, all the NAFLD cases should be renamed as MAFLD. Now, these are the diagnostic criteria proposed for MAFLD. Hepatic steatosis in adults, 5%, as we have seen, either by histology or by the ultrasound, in an obese person or a diabetic person. So, normally metabolic syndrome is combination of 3: diabetes, obesity, hypertension, TG more than 150, and HDL less than 40. Out of these 5, 3 should be present, and that the chances of having non-alcoholic fatty liver disease and NASH are more. So overweight patients can be associated with MAFLD, diabetes can be associated, and in a person who has BMI less than 25 kg per square meter in Caucasians and less than 23 kg per square meter in Asians, at least 2 of the following criteria should be satisfied. Waist circumference for Asian, more than 90 by 80, 90 for male and 80 for female. Blood pressure of more than 130 by 85. As I was telling, TG of 150, HDL of less than 40, pre-diabetic fasting sugar between 100 and 125, and a post-meal sugar between 140 and 199, HOMA resistance of more than 2.5, and CRP more than 2. So if you have at least 2 of these criteria, that can be included as a lean NASH. Now, what is a lean NASH? It's a distinct entity. I want to say that because this is also very common in Indian population. NASH in a non-obese or non-overweight person who has a BMI less than 23 kilogram per square meter of body weight, the prevalence ranges from 5.1 to 16.4, and the 20%, roughly it would be say that in 20% of the NASH population, it's 1/5 of the NASH population is a lean NASH. There are studies by MR spectroscopy or PDFF, which the investigations which will to know the exact fat content. The prevalence can be high in Hong Kong, up to 20% of lean NASH. How does it differ from the obese NASH? They are mostly younger males. Metabolic factors like diabetes, hypertension, increased lipids are less. They have lower steatosis, lower fibrosis. They have severe lobular inflammation. There are distinct differences between, so young males, less metabolic factors, low steatosis, low fibrosis, more inflammation. It is said that the visceral obesity is responsible. The genetic factors are probably responsible. PNPLA3, apolipoprotein 3, these are more common. Environmental factors are very important in these. Increased fructose in the diet, soft drinks, juices, sugars, increased cholesterol in the diet. So these are responsible for the development of lean NASH. Now, what is the management? I would see here that the histology-wise, there are conflicting reports. Some they say that this is a lean NASH is a mild disease, but some studies say that they have same macroinflammation as this thing, and as far as management is concerned, is more or less same. Reduction of weight, even if you are lean. What is the natural history of NAFLD? This is very interesting. This is in a paper published in 2015, the progression of fibrosis in patient with NAFLD versus NASH. And this was a meta-analysis of 11 paired biopsy studies, 411 patients which were followed for about 5 years, and they had a paired biopsy. So these two groups are there: plain fat without inflammation, NAFLD 150 patients, NASH 261 patients, and the progression of fibrosis in a plain NAFLD occurs by one stage in 14.3 years. So it's much slow progression if you have plain NAFLD. As compared to that, in a patient with NASH, one stage progression would occur in 7.1 years. There was another study by Pice published from Paris, where they've shown that bland NAFLD, only fat, no inflammation, progression very less. But even if there is a mild fibrosis, the progression is very fast, especially when you have diabetes factors like diabetes, hypertension, obesity, and metabolic syndrome. So the crux of the matter is, now this subset of the patient with different fibrosis progression, plain NAFLD versus NASH, the slow progression and the rapid progression. So as you can see here, whatever we discussed, that the progression is more in NASH as compared to NAFLD. NAFLD is a spectrum of the disease where you have hepatic steatosis to begin with, that 25% of these patients go on to develop NASH, and about 3 to 5% of patients with NASH, about 20 out of 20, 1/4, as Sharad has said, that they go on to develop cirrhosis, and the incidence of SCC is less. I would say about 0.5 in 0.5%. So 1 in 200 cirrhotics will have SCC, hepatocellular carcinoma. Now, why is NAFLD important? One, it's very common, high prevalence. It is one of the commonest cause of asymptomatic liver enzyme elevation. It is a commonest cause of cirrhosis all over the world. The most common cause of liver cirrhosis is fat in the liver, then alcohol, then hepatitis C, and then hepatitis B. So leading cause of cirrhosis, it is responsible for more mortality than patients without. The three important causes of mortality are cardiac, liver, and cancer. More obese patients, they have more cancer. Even if you have NAFLD, the liver-related mortality is around 15 to 20 times more in NASH. And overall mortality is also twice more with NASH than NAFLD. And of course, more than normal persons. And it's a third, even though the SCC develops in 1 in 200, the third most common of SCC in USA, next to Hep C and alcohol, is NAFLD. It is, as a clinician, one has to diagnose NASH in a patient with NAFLD. Now, normally what we do is you do the liver enzymes. What is the positivity of liver enzymes as a prediction of NASH? 50% they are correct. Persons with liver enzymes elevation, 50% would have NASH, 50% may not have NASH. So we cannot use liver enzyme elevation as a criteria for NASH. Problem is getting a liver biopsy, which is a gold standard for the diagnosis of NASH, is unfortunately cannot be practiced in clinical practice. So we have to identify patients with NASH in patients with NAFLD. So advanced age, as the age advances, the chances of inflammation are more. Postmenopausal women, increase prevalence in Hispanic population, less in blacks, hypertension, obesity, metabolic syndrome, more chances of NASH, AST more than ALT, low platelets, they are indicators of fibrosis. Persistently elevated ALT is also associated with increased risk of NASH. So how to diagnose? Now, I'm saying how to diagnose NAFLD. So first line screening investigation, but you need to have about 25% of fat to diagnose on ultrasound. It's operator dependent, but it's one of the commonest investigation done in clinical practice. Grading of ultrasound is if you can see diaphragm and portal tract, then it's grade 1, but more echogenicity. Grade 2 is you can't see the portal tract. Grade 3 is diaphragm and portal tract both are obscured and there is increased echogenicity. It is grade 3. Transient elastography. I would like to spend some time on this. This is one of the investigation, which is one of the important investigation, measures the stiffness of the liver. By the ultrasound vibrator, the waves of low amplitude, low frequency waves are created, and that when they traverse through the liver stiffness is measured. And depending upon the stiffness of the liver, you get the reading in kilopascals. So, and then the different grades of fibrosis are defined. Normally, it explores about 100 times more area than liver biopsy. And the studies have shown that transient elastography has a absolutely good correlation with liver biopsy, more than 90% correlation. And as I was telling you that the area is more than 100 times that of liver biopsy. And this is to show you that the F4 fibrosis and F0 fibrosis, that the waves, they get stiffness. But the caveat is that any patient who has jaundice will have stiff liver. Any patient who has congested liver can do faster. The test has to be done in 3 to 4 hours fasting state. If you have liver enzyme elevation more than 200, probably the stiffness would be there. So all you have to rule out is acute viral hepatitis, congestive hepatomegaly, all these things have to be ruled out. And then there are some limitations that 5% of these patients, mainly in obese persons, because of the narrow intercostal space, you can't get the reading, not feasible with ascites. So an extremely obese person, so 5 to 10%, but you have a different probe which is responsible, that helps in, getting the disease. I would recommend transient elastography or in all the patients of metabolic syndrome. When they have metabolic syndrome, we started doing this investigation with us. We have a fibroscan for echosense, and to our surprise, we get cases like cirrhosis diagnosed at a very early stage using this technology. And if you tell your patient that you are suffering from cirrhosis, he will immediately start reducing weight, controlling diabetes, and controlling hypertension and dyslipidemia. So it has a management barrier. So these are the Metavir scoring system for fibrosis. Mild is portal fibrosis, moderate is septile there, severe fibrosis, and F4 is cirrhosis. And then the RP is another ultrasound-based investigation, which acoustic radiation frequency impulse, the ultrasound wave is passed, and depending upon the resistance, it has an advantage that it is mounted on the ultrasound, and with the ultrasound, you can judge the stiffness. But the only disadvantage of RP is that the values are not standardized for different diseases. So they need to be standardized. CT, MRI are hardly used for detection of fat. They have a 70% positivity. MR spectroscopy is a non-invasive accurate method in detecting hepatic triglyceride. But the main method which is used for detecting fibrosis, a gold standard, is MR elastography. MR elastography is 94% sensitive, can measure the stiffness. The only problem is this is not available in many cities, and but transient elastography is available in many parts of the country. PDFF, proton density fat fraction, is the MR-based technique, and it can detect 1% change in the fat. So this is predominantly done for a research purpose, but it's one of the common technique which is used for all the research trials, and PDFF is the popular radiological technique used. Now, as I was telling, that radiological means are the good ones with the sensitivity and specificity more than 90%. There are non-invasive fibrosis tests which are there, but these are like APRI, AST-ALT ratio and platelet ratio, FIB4, which considers age, AST-ALT platelet, NAFLD fibrosis score, which include 3 clinical parameters: age, BMI, diabetes, AST-ALT platelet, and albumin, and the other scores like proprietary tests like FibroTest, Fibrometer, ELF. All these tests are there, and out of these, 2 tests are very important, which I'm going to discuss: NAFLD fibrosis score and FIB4 score, which are mainly used in clinical practice. Now, what happens is, to increase the sensitivity, you have to have a low cutoff. To increase the specificity, we have to have a high cutoff. Now, it is observed that when you have low and high cutoff, majority of the patients, they fall in the intermediate range, and all these blood tests have a positivity of around 80% in detecting fibrosis. So the bottom line is they would need a second test to confirm the diagnosis, and hence Radiological tests like transient elastography, MR elastography are better. The gold standard for diagnosis is liver biopsy. Of course, the high cost, discomfort, sampling error, and the complications take the liver biopsy, not a popular method. Now, the most important thing which decides the mortality is fibrosis. And the fibrosis is the one which, if the fibrosis is more, the chances of mortality are very high. Liver-related mortality very high. So, whom to treat is an important thing. All the guidelines, they say that if you have plain NAFLD, no need of treatment. If you have NASH, progressive NASH, NASH with metabolic syndrome, NASH with necroinflammation, they have to be treated. And that's the bottom line. Now, the major crux of the treatment is lifestyle modification. Diet, exercise are the main important management tools which we have. Drugs, not a single drug has been approved by US FDA for a diagnosis for the treatment of NAFLD. Not a single drug up till now. So, if you have a steatosis, depending upon the weight loss, the improvement occurs. Steatosis improve with 5% of weight loss. The inflammation reduce when inflammation improves when you have 7%, and fibrosis improves if you have a 10% of weight loss. So you have, I mean, depending upon weight loss is very important. So caloric restriction, the most important thing is caloric restriction. Macronutrient, what are you taking? Carbohydrates, fat, and proteins may not be that important. That's the second importance, but your diet should contain 50% of carbohydrate, 30% of lipid, and 20% of proteins. Your diet should be light. Change in the diet composition, increased physical activity, improved sleep, behavior counseling. Now, this was a paper published in Gastroenterology 2015, where they have done, this is the first time biopsy confirmed resolution of NASH in 293 patients with paired biopsies. Biopsy at the baseline and after 1 year when they were fed 750 kilocalories less diet and they were walking about 200 minutes per week. So around 45 minutes per day, 5 days. Follow-up biopsy was done after 1 week. This was by Villar Gomez. And, you know, I just said that a degree of more than 5% weight loss was seen in 30% patient, more than 10% weight loss was seen in less than 10% of patient, but was associated with 90% resolution of non-alcoholic steatohepatitis and 45% resolution of fibrosis. So weight loss is an important thing. Now, between diet and exercise, what is important? I would give more importance to diet. Caloric restriction is more important. Reduction of calories by 30%, 750 per day, improves hepatic steatosis and insulin resistance. Mediterranean diet, monounsaturated fatty acid, better than high fat, low carbohydrate diet, has been shown and proven on MRI to reduce fat. Mediterranean diet contains leafy vegetables, onion, tomato, fish, olive oil. I mean, these is supposed to be better and weight loss should be achieved. The oils which should be used in cooking should be the unsaturated, monounsaturated MUFA or PUFA, olive oil or omega-3 containing oils are better. Role of exercise. Lack of exercise may lead to this diabetes, metabolic. Exercise advice as a part of why exercise is beneficial, reduces weight. Weight independent effects are also there. There are no large trials, but 150 minutes walk per week reduces aminotransferase, and high exercise more than 6 milliequivalent improvement in NASH and fibrosis. Aerobic and resistance, both are known to improve. Diet plus exercise, I already projected a data of both. Weight loss is important to decide. And all these lifestyle changes, have been emphasized in guidelines like EASL, NICE, Asia Pacific, ASLD, and Italian guidelines that you restrict the diet, improve the physical exercise, and that's a gold standard of treatment. Pharmacotherapy, to say that for a disease like this, the therapy is almost like for many years, lifelong, and none of the drug is improved. So there are three things in the pathogenesis. You have abnormal bacterial flora, increased intestinal permeability, and more inflammation in the liver after the accumulation of fat. So basically, the drugs will be acting on all these levels. So because there's no time for going for pathogenesis in details, but insulin resistance is the crux, and the dysbiosis, intestinal permeability, inflammation, pro-inflammatory cytokines, a diet like fructose, saturated fatty acids. So you have drugs which are anti-inflammatory drugs. We have drugs like anti-fibrotic drugs. You have drugs which act on the metabolism, especially the lipid metabolism. So these are the drugs which are there: metabolic, anti-inflammatory, anti-fibrotic. What are the end points of treatment in all these trials? See, there should be resolution of steatohepatitis, and there should not be worsening of liver fibrosis. Normally, NASH resolution is taken as one, total resolution is taken as important criteria. But in many clinical trials, reduction of NASH score by more than 2 is taken as a criteria. Fibrosis improvement more than one fibrosis stage, and no worsening of steatohepatitis is the end point. This is a P1's trial, vitamin E, a famous, published in New England Journal of Medicine by Arun Sanyal, who has a lot of work on NAFLD, histological resolution of NASH at week 96, that is nearly after 2 years. And there were 3 arms: placebo, vitamin E, and pioglitazone. With vitamin E was twice better as compared to placebo in biopsy-proven NASH without diabetes. But the benefit of vitamin E is also shown in a retrospective study. It improves the transplant-free survival and hepatic decompensation in patients with NASH and advanced fibrosis. So these patients who had nearly cirrhosis, compensated cirrhosis, were receiving vitamin E, and retrospectively when 90 patients with vitamin E and controls were compared, the transplant-free survival was 78% in vitamin E group as compared to 49%. Decompensation was 62% in control with 37%. However, what is commonly thought that the vascular event, cerebrovascular event, non-hepatic cancers like the prostatic cancer are not more, same also the SCC. And the benefit has been not only seen in diabetic, but also in non-diabetic patients, not only seen in non-diabetic, but also in diabetic patients. So there is a point for vitamin E, and this trial was done for a long period of 5 years. So they have this retrospective data by Naga Chalasini group. The Farcenoid X receptor pathway, obitocolic acid, a new kid on the block. Everybody is excited to receive obitocolic acid, probably one of the first drugs which has shown anti-fibrotic effect in clinical trials. It's a wonder drug as far as mechanism is concerned. It acts on the lipid metabolism, less triglyceride synthesis, excessive clearance, less VLDL formation, prevents neoglucogenesis, reduces bile acid synthesis, promotes excretion, anti-inflammatory action, anti-fibrotic action, anti-atherosclerosis action. So farcenoid is favorable in liver regeneration and hepatocarcinogenesis, contribute to the protection of atherosclerosis and liver disease. And this is one of the first trial, the obitocolic acid trial in Flint trial, a phase 2 trial, which has shown a benefit of obitocolic acid in the dose of 25 milligram as compared to placebo in reducing NASH and fibrosis, both as compared to placebo. So 45 placebo, 21% had achieved the end point as compared to 45%, nearly twice people, they achieved the end point with obitocolic acid of improvement of fibrosis and NASH resolution. And this is a famous regenerate trial, a phase 3 trial of obitocolic acid. The trial is still going on. The interim analysis of the trial, which was published very recently, about 3 or 4 months back, has shown that the obitocolic acid 25 milligram for 72 weeks improved fibrosis and other histological features of NASH. And the benefit is more with 25 milligram than 10 milligram. The target is 2,400 patients randomized in 3 groups of placebo, 10 milligram and 25 milligram. And the results are exciting. You see that the primary endpoint in the form of fibrosis improvement more than 1 stage and no worsening was seen, achieved in twice the number of patients as compared to placebo with 25 milligram. However, NASH resolution was not seen that statistically significant, but the fibrosis improvement was noted. And as you can see here in the third column, that in the placebo, 20.9, nearly 21% worsened fibrosis as compared to 25 milligram OCA, only 13% worsened and 38% improved. So this is probably the first drug which has shown benefit in terms of fibrosis improvement. Up till now, we did not have any drug. So the conclusions was 65% normalized ALT. There are 2 side effects of these drugs: increase LDL cholesterol, but this LDL cholesterol was not associated with higher coronary events. Pruritus was reported by 51% of patients with 25 milligram. So 2 side effects, 2 drawbacks: pruritus and increased low density lipoprotein cholesterol. This treatment discontinuation was similar in 3 groups, more with 25 milligram. So probably this was the first successful trial, but presently there was a letter received on 29 June 2020 that it's not been approved by FDA for steatohepatitis. The treatment is long. Selenosertib, we were probably part of this trial of Stellar 4 and Stellar 4, Stellar 3 and Stellar 4, and unfortunately, because of the interim analysis showing no benefit, the drug has been withdrawn. So, and same is happening to many of these drugs in NASH trials. So, up till now, obeticholic acid stands a chance of getting approved. Saroglitazole, an Indian drug which has different mechanisms that it reduces steatosis, reduces inflammation, reduces fibrosis. It's a drug which acts on PPAR receptors, peroxenoid receptors, alpha and gamma, and thereby reduces the steatosis and promotes the mobilization of fat from the liver to the periphery, reduces inflammation and reduces fibrosis. Indian data on saroglitazole, a phase 2 trial, have shown that saroglitazole this was the biopsy-proven trial, 102 adult patients with biopsy-proven NASH without cirrhosis and having activity which is more than 4. Saroglitazole 4, we were also part of this trial, and the NASH activity score, steatosis, lobular inflammation, and hepatocyte ballooning was improved in twice more number of people than placebo. This was again a result of saroglitazole randomized trial. Complete. You can see the improvement in ALT, AST, ALP, and GGT almost twice more as compared to placebo. Even the lipids, it's a drug which improves the lipid parameters, so triglyceride, HDL, VLDL, total cholesterol improved. Alafebrinol, again another PPAR agonist. It affects alkaline phosphatase GGT, and the enzymes are better done with 120 milligram dose. The results of alafebrinol phase 3 trials are expected to come by next year, 2021, in July. The other therapies like UDCA is commonly used, silymarin, there's no sufficient data, omega-3 fatty acids, there's no sufficient data for the improvement of NAFLD. So basically, majority of the guidelines, they consider the use of vitamin E and the PPAR agonist like saroglitazole. The pioglitazans have been also, obeticholic acid as still awaiting the lubiprostol. It's a Japanese trial. I'm coming to the end of my presentation. Double-blind placebo randomized phase 2 trial, which has shown that the parameters of gut permeability improved as measured by lactulose fructose breath test. And there is a significant reduction in MRI PDFF, proton density fat fraction, in lubiprostol group. By and large, lubiprostol is used as a drug used for constipation, 24 microgram higher adverse effects than placebo, but that's so these drugs acts on 2 ways, changes the bacterial flora and the gut permeability. Last word on FMT, because there is lot is spoken about the bacterial flora in NASH. There are experiments that the bacterial flora from obese mice is, when it's transplanted to a germ-free mice, the germ-free mice becomes obese, suggesting that there is a role of bacterial flora. And this is the first trial of allogenic fecal transplant in non-alcoholic fatty liver disease. Again, a negative trial that there was no significant change in insulin resistance and hepatic PDFF after 6 weeks of allogenic transplantation. Only the permeability of the gut improved. This is published very recently in 2019 or 20 in American Journal of Gastroenterology. So mainly you have drugs acting on the lipid metabolism like obeticholic acid, FXR, PPAR like saroglitazole and elafibranol, GLP-1 analogs like liraglutide, semaglutide, which I think Dr. Ambulkar will cover. And then you have anti-inflammatory drugs like vitamin E, which is a prominent. Methodoxin, not much trial. Drug, which is a pan-capsase inhibitor, emricazine, done in recently in UEGW 2020. It has been shown that this drug is again not useful and for the treatment of NAFLD fibrosis. Selenosertib and Senvi-Crivi-Rock, these are the anti-inflammatory drugs which are in the pipeline, but their results are awaited. So conclusion, this probably last slide, NAFLD is quite common in clinical practice. 1/4 of the population, 1/4 of the NAFLD have NASH, which is more progressive than NAFLD. Identify metabolic syndrome, find out fibrosis as it decides mortality. Transient elastography, MR elastography, RFE, these are the shear wave elastography are the techniques to identify. The blood test have 80% positivity. Diet, exercise, lifestyle modification are the main armamentarium of treatment. Weight loss, crux of the matter is weight loss associated with significant improvement. Vitamin E, saroglitazole, obeticholic acid are presently the main drugs of treatment. Treatment is lifelong. Thank you very much.
Well, thank you, Shrikant, for an excellent lecture on the NAFLD, how to diagnose it and how to treat and what are the various options for treatment. And what it appears like from your talk is that patients who have simple steatosis or NAFLD, probably they just don't need any treatment, but just a weight loss of 5% helps them. And probably we are not looking at pharmacotherapy. And those patients who have inflammation, that means patients who have NASH and associated with or without fibrosis, they are the candidates which need some kind of more aggressive approach. And probably amongst the various options of treatment which you described, the one which appears to be very emphatic is about 10% of weight loss. And probably that is very important to be recommended to your patients, that you need to first identify that these are the patients who need to be very aggressively treated. And a proper investigation for that, as you said, is elastography, transient elastography, which can go miles to identify those patients who have F1, F2, F3, F4 fibrosis. And probably you would agree with me that right from F1 fibrosis, you will like to treat them more aggressively, isn't that? Yeah. So
any stage of fibrosis, you should be alert.
Yes. And then the researchers always looked at two things, that whether the steatosis is getting better, whether the necroinflammation is getting better with the pharmacotherapy. And the most important thing is that the researchers looked at whether the fibrosis gets reversed. And then you have drugs like say pioglitazone, vitamin E, which helps in reducing the steatosis and inflammation, but perhaps they are not capable of reversing the fibrosis. But now we have started getting drugs like say obeticholic acid, as you mentioned, and probably saroglitazole to some extent, which have been able to reverse fibrosis, not to the complete extent, but to some extent. I think with this summary, if there are any questions.
Sir.
Yeah.
Sir, yes, sorry. It was a technical difficulty with me as being the president of API Vidarbha chapter. Actually, I had to talk earlier, so I will take just 1 minute of yours. So I really appreciate this webinar and all the faculty, eminent faculties, as well as our sir moderator. So Dr. Shrikant Mukewar sir, who has given a wonderful lecture on this particular topic. Then we have got Dr. Sunil Ambulkar, needs no introduction, who is a known endocrinologist. He's an head of the department of even endocrinology department at GMC Nagpur. Then we have got the Honorable Dr. Raj Gajbia sir, who is professor and head of surgery at GMC Nagpur again. And he's also consultant in bariatric surgery. And we have got the young person, Saurabh Mukewar, who is a gastroenterologist who has done everything from abroad. And he's very much he's basically trained in advanced endoscopic interventional in hepatology and liver transplant. So I really appreciate the efforts of everybody for making this webinar wonderful one. Please excuse me because of some technical difficulties. I was late to join. So I think this is how actually is a virtual thing which we are I think able to do it because most of the activities of API this year could not be done since March, and I hope now in few months probably we'll be able to do it. I have been given an extra charge and or other my term extended for another 6 months because it was the 31st of July when my term was ending. But then the executive committee decided that I should continue till this particular COVID pandemic is there. There is no other option than to continue. So I really appreciate the efforts of everyone who is doing whatever best they can do for the suffering humanity. So with these few words, I welcome you all the eminent speakers, our moderators, sir, and all the API members and the other people who are who have joined this webinar. So thank you very much, and please excuse me for being late. Sir, over to Sir Sharad, sir.
Oh, thank you so much. So should we take questions, answers here?
I think
Shahid?
let the complete thing be over. So then
should
it
we
will be better.
go for a second lecture?
Yeah.
Should I request Saurabh to take up his lecture, endoscopic treatment of NASH? As it has already been introduced that Saurabh is an upcoming gastroenterologist. He has been trained for advanced procedures, endoscopic procedures abroad and in very reputed institutes like Mayo Institute and at Chicago, I suppose. Am I right, Saurabh?
In UCLA and Columbia University.
Yeah. And he has been instrumental in sort of introducing some very novel techniques at Nagpur. And he's up here to speak on endoscopic treatment of NASH. I'm very keen to listen to him. Please go ahead, sir.
Thank you for the kind introduction. And we miss working with you, I must say.
Oh, no,
and your guidance.
It's not going to be for long.
Yes. And it was really nice to see Chan ma'am also, who was my teacher during my final year days in GMC. And nice to see Dr. Gajbia sir as well and Dr. Ambulkar as well. Thank you. I'll just start my presentation. 1 second. Sorry. Let's see. Second. Okay. All right. Okay, so this is all right. Can everybody see, right? Yeah. Okay. So I'll be talking about sort of a new sort of treatment modality, or excuse me, sorry. Yes, so I'll be talking about endoscopic management of obesity, and more so in the context of NASH. I have I've been trained in gastroenterology, and then this is sort of the area where two of my advanced trainings interact, where I've been trained in advanced endoscopic procedures as well as management of liver patients, and therefore combining the two fields uh, in this topic, so to speak. So what we know about obesity is excess of body fat. It's difficult to measure it quickly and cheaply. What we use is a surrogate marker, which is body mass index. Body mass index is calculated with weight and height. Overweight is usually once you're above 25, and class 1 obesity, and class 2 and class 3 above 30, 34, and 40. The ranges for obesity in West versus in Asia or India are different, where overweight is considered when our BMI is above 23 in India. And if our BMI is above 25, then you are talking about class 1 obesity. So this categories are a little different. The data and everything else that we have been going by is largely from the West, but we have to bear in mind that in Indian context, the numbers are different. Okay. So in India, obesity is common, more than 135 million people affected. Prevalence ranges anywhere from 17 to 36%. What we understand is with regards to pathogenesis of NASH, obesity and hyperglycemia are both implicated in pathogenesis of NASH, as has been outlined in the previous talk, and we will not get into this. Just the available medicines, exciting times with the availability of obeticholic acid, but by and large, none of the medicines have shown a significant effect thus far in terms of reducing weight or reducing NASH progression. So what we have learned, as I'll be quick in this slide, is that weight loss is your best modality for treatment of NASH, as was shown in this paper in gastroenterology with pre and post NASH biopsies, where if you achieve a more than 10% weight loss, as you focus on the bottom part of the screen, 90% patients had resolution of NASH and 45% had regression of fibrosis. So weight loss is what we would like to aim to achieve, although the newer medicines seem to be promising, and maybe a combination of weight loss with the new medicines may be the way to go going forward. Weight loss is not easy. What we have seen, this is a New York Times article. There's a show in the US called The Biggest Loser, where it's a reality show where morbidly obese people do exercise and weight and dietary changes to lose significant amount of weight. They had about 14 participants losing hundreds of pounds of weight. But the problem is they all gain the weight back. So after losing significant amount of weight, in this series, 13 of the 14 contestants regained weight, and actually 4 were actually heavier than when they started. So although desirable to go with routine exercise and diet for losing weight, this can be challenging for most people, and regain of weight is quite common. So if you look at sort of treatments for obesity, you have lifestyle measures, which, as I said, is less efficacious, but the risk is obviously much lower. But and then as you move forward, you have some medications which induce weight loss, moderately effective, a little more, but mild side effects, if any. Then we have endoscopic procedures, which the efficacy goes up, and then the risk is slightly more because it's ultimately a procedure. And then at the far end of the spectrum is surgical procedures, which Dr. Gajbia will be outlining later, where when we look at a much higher efficacy in terms of weight loss, but obviously it's a surgical intervention, so has more adverse events. Okay, so if you look at endoscopic options for weight loss, there are intragastric balloons, which have been around for a long period of time. Then we have newer endoscopic procedures, the aspiration therapy. This is available in the US. It's like a reverse peg where basically food is removed from the stomach. The POSE procedure on the endoscopic sleeve gastroplasty, ESG is now available in India and can be performed. POSE is more experimental as of now. And then we have procedures and options targeted at small bowel, which serves mostly for control of diabetes and less for weight loss. And then some exciting new developments, which is an incision-less anastomotic system, which I'll just share with you later. So which patients are to be considered for endobariatric therapy? We are looking at Western data, BMI above 30, and they need to be medically fit to undergo an endoscopy and get anesthesia. Multidisciplinary approach is important. It's not just the person performing the procedure, but a physician, psychology involved, psychiatry and psychologists, dietitian, counseling is essential for treatment of such patients. So just an illustration for endoscopic sleeve gastroplasty. Basically, the endoscope is advanced into the stomach. And then using argon plasma coagulation to make markings in the mucosal wall. And then the endoscope fitted with a suturing device is used to basically create sutures internally and make this stomach smaller in size. Okay. So this is continued. And as you see here, the size of the stomach is reduced internally. So just show you a case. This is while I was in New York as a faculty, where a patient, 28-year-old male with class 2 obesity, presented to the bariatric clinic. Patient was 95 kilograms, BMI was 34. Comorbidities included NASH and diabetes. AST/ALT was 52 and 65. Patient was interested in endoscopic sleeve gastroplasty. The procedure was performed, and I'll illustrate the video of the procedure. So this is towards the end of the stomach. This region is the antrum, where this is the device, which suturing device, which is fit on top of the endoscope, and then serially suturing is performed with one after the other. The bites are taken and forward. All right. Yeah. So the device is actually quite simple and easy to use for somebody who's performed endoscopic procedures. The learning curve can take about 20 to 30 cases, and mostly following that, this is quite doable. Just move forward here. So this is towards the end of the procedure, where the endoscope is advanced into the gastric antrum and right there. So that's sutures over there. All right. So after 6 months, this patient lost 18 kilograms and reduced the dose of anti-diabetic medications. There was an improvement in AST from 52 to 45 and ALT from 65 to 53. So the mechanism of endoscopic sleeve gastroplasty is basically by increasing gastric retention, as illustrated in this mechanistic study, where gastric retention at 4 hours after the performing procedure showed food retained in the stomach. This basically leads to increased satiety. The fluoroscopic image on the bottom right shows the sort of the sleeve created with the help of endoscopic sleeve gastroplasty. So as we look at outcomes in these patients, let's understand some basic terms. What has been considered as a total weight loss percentage, which is basically the amount of weight lost divided by initial weight times 100. So if, for example, if an 80 kg patient loses 16 kilograms of weight, you're looking at 20% total weight loss. The goal of any bariatric intervention is by and large to get more than 5% total weight loss. The other term thrown around is excess weight loss percentage, which is basically the excess is the weight loss divided by excess weight. Now, excess weight is the amount of weight more than your ideal weight. So, for example, 80 kg patient loses 16 kilograms. Ideal weight is say 60 kgs, then the excess weight is 20 kilograms. So excess weight loss is 16 by 20, which is 80%. The goal of any bariatric intervention is to achieve more than 25% excess weight loss. So if you see the weight loss from sleeve gastroplasty, overall from various studies from Madrid, Rochester, which is my where I was before at Mayo Clinic, and in New York, where my colleagues were recently, where I was recently before moving back. 6-month weight loss was 15% total body weight, and at 24 months it was 18.6. So about what we can expect for patients is about 20% total body weight loss over time. This is a meta-analysis of 1,772 patients, where overall the weight loss is 17% total and 67% excess weight loss from endoscopic sleeve gastroplasty. So, long-term outcomes, this was just published recently now. The total weight loss at 5 years, it's sustained at about 15% from the data, and more than 10% total weight loss was accomplished in 70% patients at the end of 5 years. It's a very safe procedure, actually. A rate of severe adverse events, which would be, say, 2%. In fact, 1% was patients having pain or nausea requiring hospitalization. So overall, upper GI bleeding in 0.5% or a perigastric leak in 0.5%. So by and large, most patients tolerated quite well. How is it compared to laparoscopic sleeve gastrectomy, which is performed with laparoscopic technique surgically? Total weight loss was slightly lower with endoscopic technique, average of 17% versus 23.6% with laparoscopic sleeve gastrectomy. Adverse event profile was less, 5% with endoscopy, about 17% with laparoscopic sleeve gastrectomy. GERD was much lower in the endoscopy arm versus the surgical arm. So that's the data. ESG is, we term endoscopic sleeve gastroplasty, improves comorbidities. The hemoglobin A1C is reduced significantly, waist circumference goes down, systolic blood pressure is better, LDL cholesterol, no difference, triglycerides reduced, and ALT levels in this study showed improvement. And I'll get to that, which is endoscopic sleeve gastroplasty in NAFLD. What's the data? So this is just hot off the press, published by my colleagues in New York, Hajif Thalian and the team. So 118 patients underwent endoscopic sleeve gastroplasty. BMI was about 40, ALT was 58, average. The HSI, which is the hepatic steatosis index, was 52, which is high. And NAFLD fibrosis score, I'll show you in a few seconds, showed F0, F2 fibrosis in 45 patients and F3, F4 in 12 patients. Let's move forward. The outcomes measured in this study included the HOMA-IR score, which is a measure of insulin resistance, and the NAFLD fibrosis score, which is a composite score with age, BMI, diabetes, AST-ALT ratio, and platelet count. Basically, this is a non-invasive score based on labs and demographic parameters, where less than negative 1.4 is F0, F2, and above 0.0675 is F3, F4. Anything in between is indeterminate. So it's not a perfect measure, but can be helpful. So in this study, following ESG, there was improvement in insulin resistance and the hepatic steatosis and fibrosis. At the bottom left here is the insulin resistance, which went down significantly. And if you look at the fibrosis scores, baseline, say 43% patients had F0, F2 fibrosis. This went up to 61%, and the score of F3, F4 fibrosis went down to 7%. In terms of variables, the AST and ALT levels, absolute change was -5 per year and -3 per year with AST. HSI reduced by 4, NAFLD fibrosis score went down by 0.3, and all these things, all these variables were significant. There are several ongoing trials for endoscopic sleeve gastroplasty NAFLD. There's a Spanish randomized controlled trial using ESG plus lifestyle versus sham endoscopy. Another trial comparing ESG with laparoscopic sleeve gastrectomy. So there's a lot of data on the way, but whatever we have seems to show that it's quite effective. And there's a hint that it does improve hepatic parameters. Okay, so let's move forward. Intragastric balloons. This has been around for a long time. And what we have in India is the Orbera intragastric balloon system. SPATS, the previous version, has fallen out of favor. I think this is probably available in India. On the top left, this is a Reshape. This is out of market right now. Ellipse and Obalon are the ones which are not endoscopically placed, but this is done with swallowing. So this is not available in India right now. So just to illustrate video of intragastric balloon, this is quite simple, where the balloon is basically inserted in the stomach and inflated with normal saline, and it's again reduces the size of the stomach, and eventually after 6 months it's taken out. Again, the mechanism of action is similar to sleeve gastroplasty, with increase in gastric retention. If you look at outcomes with intragastric balloon, just focus on Orbera, which is available in India. If you see the BMI in this randomized controlled trial, no difference between the control and the active group. The percent total body weight loss in the control group was 3.3%. The active group was 10%. So we are looking at something about 10%, which is less efficacious than sleeve gastroplasty. The adverse events, the problem with intragastric balloons is patients have mild adverse events, but this can make it intolerable for patients. So vomiting, nausea in 50 to 80%, abdominal pain, discomfort, abdominal discomfort, eructations, dyspepsia in 20%, and GERD in 30%. Post-procedure management, patients develop abdominal pain and nausea is sort of expected. So it's important that the patients are medicated preemptively prior to these procedures, and diet modification is very important. Let's look at the data for intragastric balloons in NAFLD. So before we proceed with looking at the data, let's understand the scoring systems. For biopsy, the parameters assessed include steatosis, which is scored from 0 to 3 based on the percentage of fat cells, fatty liver cells. Ballooning scored from 0 to 2. Lobular inflammation scored from 0 to 3. Total score is, if it's between 1 to 4, is simple steatosis. Steatohepatitis when the score is between 5 to 8. And then additionally, fibrosis is graded from 0 to 4, where 0 is none, and then stage 4 is cirrhosis. So with this context, I'll discuss the data. So this is again a more recent study. This is out of Mayo Clinic with my colleague Fateh Bazarbaichi. This is an intragastric balloon placement in 21 patients where they did pre and post liver biopsies. 21 patients were enrolled. And as you see, before and after, the BMI significantly improved from 43 to 38. Weight reduced, waist circumference went down. The hemoglobin A1C reduced from 7.7 to 6.5. The LDL cholesterol slightly improved, but not statistically significant. The AST ALT levels improved quite impressively from 67 down to 31. ALT down from 91 to 39. And then the NASH activity score down from 4 to 1. They did even MR elastography, and there was significant improvement from 3.5 to down to 3.2. So just to illustrate in a different manner, steatosis, ballooning, inflammation, all reduced. The NAFLD activity score on biopsy reduced. Unfortunately, there was not much improvement in fibrosis. A couple of patients in stage 3 actually got worse to stage 4. But by and large, the other markers did show improvement. This is again illustrated in a different manner with percentage improvement in steatosis, ballooning, inflammation, and the NASH activity score. This is another old study, actually one of the earlier ones, in which small pilot study, 8 patients got intragastric balloon, 10 underwent sham procedure, pre and post liver biopsy was obtained. Again, there was improvement in the NAFLD activity score on biopsy from almost 5 down to 2 in the treatment group, and not so much in the control arm. This was significantly different. So if you look at the data overall, what we have is mostly for the Orbera intragastric balloon. And I illustrated the 2 studies in which the biopsies were performed. So the other studies, if you see, from various centers in Spain, Italy, Singapore, England, USA, and most of them had the follow-up for 6 months. This is the duration of placement of the balloon, except for the second study for 21-month follow-up. By and large, there was improvement in metabolic parameters in pretty much all the studies, with reduction in BMI, improvement in insulin resistance, reduction in triglycerides. Labs, basically, AST and ALT improved in all the patients. Liver histology, as we discussed the 2 studies, there was improvement. The other modalities to assess hepatic steatosis in the other study shows improvement by ultrasound or MRI. And in fact, as I showed you in the Basel-Breicher study, there was improvement in fibrosis on the MRI in the study. So there are other endobariatric procedures, and these are more experimental right now. The endobarrier and the Vallon endoluminal bypass on the left. The idea is basically the food bypasses the absorption area in the proximal small bowel. The Revita duodenal mucosal resurfacing. I'll show you some, it's exciting new therapy, again in experimental stages, as well as the incisionless anastomotic system. The aspiration therapy and the post procedure, which I showed you before. Again, it's not available in India. We won't go into that today. So this is duodenal mucosal resurfacing. Again, this is basically meant for diabetic patients with less effect on weight loss. I'll just show you a video GI case report. Basically, the rationale, the idea, it's really unclear, the mechanism of action, but basically nutrient bypass from the proximal intestine is basically performed. And what's hypothesized is abnormal hypertrophy of mucosa and abnormal enteroendocrine cells identified in the upper GI tract of diabetics. And therefore, sort of superficial ablation of the mucosa in the upper GI tract could potentially have beneficial effect, is the thought process. So I'll just be brief here. So it's really a very simple device and technique. Forward. Basically, the endoscope is advanced into the small bowel, guide wire is left in place. Over the guide wire, a catheter is advanced. The idea of placing the catheter and sizing the duodenum is to ensure that you know the exact size of the of the duodenum up to the ligament of Treitz. You want to avoid the papillary orifice, and therefore endoscope is advanced to ensure that it does not ablate the papilla. Next, the catheter, the balloon is inflated so that it opposes the duodenal wall. And then the needle is advanced so that saline is injected in the submucosal space so that the mucosa is lifted away from the submucosa. And this is sort of sequentially performed in the duodenum. This is in the case with the submucosal injection. There is submucosal edema, and basically the mucosa is separated away from the submucosa. Next, the catheter is advanced over the wire, and basically ablation of the mucosa is performed. So, recent data, 46 patients, ALT levels improved nicely at the end of 12 months. Not much effect on the weight. Insulin resistance improved. Hemoglobin A1C improved by about 1 point in these patients. There's another exciting data coming from, this was in the endoscopic conference presented this year, not yet published. The duodenal mucosal resurfacing was compared to the sham procedure. Overall, 39 patients in the mucosal resurfacing arm and 36 patients in the sham arm. Overall, mild adverse effects in both the arms with abdominal pain and slight diarrhea. Overall, the change in hemoglobin A1C was about 0.8 in the arm with duodenal mucosal resurfacing. And there was a change in MRI assessment of the fat fraction in the mucosal resurfacing arm, significantly more than the sham procedure. All right. Something else which is exciting is the incisionless magnetic anastomotic system. This is again experimental, one study of 10 patients where endoscopes are advanced both from mouth and the anus, and then magnets are placed in the small bowel to keep them in place and sort of lead to slow, steady necrosis and fistula formation, and ultimately leading to weight loss in patients. So with this, 10 patients underwent this procedure with about 1.9% reduction in A1C levels in the diabetics, 1% reduction in pre-diabetics, about 15% body weight loss without any serious adverse events. So in conclusion, NASH is associated with obesity and diabetes. Lifestyle measures are not successful in most patients. Safe endoscopic procedures can help achieve moderate amount of weight loss. There's emerging data to show improvement in NASH parameters after weight loss following endoscopic procedures. Thank you so much.
Well, thank you, Saurabh, for your very lucid lecture, and you have shown very exciting procedures which can be done in order to achieve weight reduction. And as we are discussing NASH, which is essentially an obesity related disorder, and we discussed today, and we have been discussing that the most important approach in all these patients is to achieve weight reduction. And as you very rightly said, right in the beginning, that reducing weight is not an easy job for most of the individuals, because they reduce weight and regain, and then every effort comes back to naught. So in this scenario, whatever procedures, and they're very, very new and novel procedures, and probably that involves a lot of skill in carrying out, and probably it needs a lot of training as well, expertise in order to perform these procedures. and the exciting results. You focused on certain trials, on various procedures, and how they had been successful in improving the metabolic parameters, and at the same time reducing fibrosis to some extent. There is always an objection to weight reducing procedures, is that the fibrosis sometimes improves, sometimes it worsens also. And that happens sometimes with these kinds of procedures. But then most of the trials which we are focused upon, they showed a lot of improvement and they were very convincing. So thank you very much for your very lucid presentation. And I congratulate once again. And let us wait for any questions for you. There are going to be a few.
Mm-hmm. Thank you so much.
Should we go ahead with the next lecture?
Sure.
Sure. You wanted to say something?
No, thank you so much. I think it's all these are new data that we have. And
Right.
I feel that all this is coming and there will be more and more data. And I do feel that there are a lot of patients, we just easily ask them to lose weight. And, although there are critiques of procedures, endoscopic or surgical, we forget the fact that, a lot of these patients, the disease progresses and their long-term cardiovascular and liver complications are almost life-threatening. So we need to really balance it out. And when such interventions are needed, it's probably a good idea to do them. Yeah.
Very well said. And I must congratulate, because the way you speak and the more I listen to you, you look like a very seasoned and a mature speaker.
No,
great.
I don't know about that, but thank you. Thank you.
Thank you very much. Let's go ahead with the next talk. Dr. Sunil Ambulkar, another stalwart and an endocrinologist and a professor in endocrinology at Super Specialty, who is going to deliver this talk, and he's going to speak on a very important topic, that is diabetes and NASH. Sunil, please go ahead. Sunil, you need to unmute yourself.
Thank you, sir. Shahid, can you put up my slides, please?
Yes, sir. We are going to share, sir. Yeah.
At the onset, I must congratulate Saurabh for his excellent talk. I heard him for the first time, and I fully agree with what Deshmukh sir has said. He has shown us many new things and many new things in endoscopic GI surgeries, endoscopic GI medicine, and I wish him all the best. And I was very happy to see young guy performing what I would say father and mother duo was excellent. Father and son duo were excellent today. My talk is diabetes mellitus and NASH. Next slide, please. In fact, Mukewar sir has done a great justice to this topic. So I will be very brief because it is around late night now. NAFLD prevalence parallels obesity prevalence. Increased calorie intake, sedentary lifestyle leads to obesity. Increased calorie intake, sedentary life leads to NAFLD. In a recent meta-analysis, risk of diabetes was twice high in FNLD. The physiological mechanisms underlying the development of NAFLD or diabetes are alteration in glucose and lipid metabolism, glucotoxicity and lipotoxicity at the level of liver, muscle, and fat cells, insulin resistance to begin with, and insulin deficiency on a later stage where all the manifestations of these both disorders will be seen. Next slide. Now diabetes leads to NAFLD and NAFLD leads to diabetes. As already mentioned, this is a spectrum from hepatic steatosis when 5% fat cells are present in the liver, leading to hepatic inflammation, followed by ballooning of the cells and lobular inflammation, leading to the fibrosis, which is a precursor for cirrhosis of liver and ultimately cancer in probably 3% of the cases of NAFLD. This disease is characterized by enzymopathy, ALT elevation, and not explained by alcohol, hepatitis, drugs, and other liver disorders. 6% NAFLD will develop cirrhosis cryptogenic. That's what we learned in our medical days, school days. Cryptogenic or idiopathic cirrhosis of liver was probably NAFLD-induced liver disease. As Mukewar sir has said, this is going to be the commonest cause of cirrhosis of liver, surpassing alcohol and hepatitis B and C. The risk is highest in age more than 50 years, overweight and obese, having type 2 diabetes, and there are hereditary genetic factors. If you have a PNPLA3 gene, then probably you will have more of NAFLDs and cirrhosis of livers. Next slide, please. What is the pathogenesis? Initially, it was the two-hit hypothesis, now which has led to multiple hit hypothesis. Hepatic triglyceride synthesis is increased. That is what is called as hepatic steatosis. Hepatic steatosis means increase in the triglyceride level in a liver hepatocyte. Fat tissues of obese person produce adipokines. These adipokines lead to insulin resistance at the liver and muscle. More insulin is secreted by pancreas. High insulin promotes more fat uptake, synthesis, and storage. Then fatty tissue in periphery release fatty acids, diglycerols, which are more hepatotoxic than triglyceride. Triglyceride per se is not that hepatotoxic, but fatty acids and diglycerols are more hepatotoxic. They increase cytokines, lead hepatocyte death. Dying hepatocyte trigger healing. Sometimes the repair process is good. Sometimes the repair process involves transient expansion of myofibroblasts, and they lead to fibrosis that make and degrade matrix. This is NASH, and NASH leads to cirrhosis, where there is a futile repair, degeneration of nodules which are not in an array, and it also leads to liver carcinogenesis, malignant transformation. So this was the two-hit hypothesis of adipokines and cytokines. Now we have multiple hit hypotheses. There's an increase in the leptin from fat cells. There's a decrease in adiponectin. Adiponectin is cardiovascular safe hormone. Then there is increase in the resistin. Resistin is the hormone secreted by fat cells, which increase insulin resistance. Then there is a role of hepatic iron, and there is a role of intestinal microbes, which is not proved, but still hypothecated towards NASH. Next slide. Now, adipose tissue insulin resistance. Adipose tissue is considered as one of the largest endocrine glands, and it secretes many hormones. The most of them are leptins, resistins, and other hormones. It increases lipolysis by releasing free fatty acid. This free fatty acid causes lipotoxicity at the level of liver. It decreases anti-inflammatory adipokine. There is a low level of adiponectin and IL-1, which are anti-inflammatory substances released by fat cells. It increases secretion of pro-inflammatory cytokines like MC11, TNF-alpha, TGF-beta, interleukin-6, and leptins. This leads to increasing resistance in liver and muscle. There is activation of pro-inflammatory pathways, and there is impaired insulin secretion. So the story starts with insulin resistance and ends with decreased insulin secretion. This lipotoxicity hampers the function of pancreas over a period of time, in addition to glucotoxicity, and leads to diabetes, and the same function can lead to hepatic steatosis, steatohepatitis, and further cascade. So this is what diabetes does for a patient of liver. This is the liver problem can do to to diabetes. And the bottom line of these two is obesity. Obesity because of exogenous fat and endogenous fat, leading to a lot of hormonal interplay. Next slide. So what happens in these two disorders is the insulin sensitivity goes on decreasing, insulin resistance goes on increasing, the insulin clearance goes on decreasing. Initially, there is an increasing insulin secretion, but over a period of time, there is a beta cell exhaustion, beta cell dysfunction, and there is how the beta cell fail. If the beta cell fail more than 50%, the hyperglycemia starts and it goes on rising. This is an ongoing process. And the patient moves from normal glucose tolerance to non-diabetic, then the frank diabetes. Similarly, patient moves from hepatic steatosis to further stages of this problem. So this is the natural history of diabetes in contrast with NAFLD. Next slide, please. Next slide, please. Now this insulin resistance is not only at the level of liver. Insulin resistance is at the level of skin also. If you look at an obese person, you will get a velvety black pigmentation in the axilla, in the groin, and the nape of the neck. This is an acanthosis nigricans. This is a biochemical marker of hyperinsulinemia. What is insulin resistance in short? If you want to maintain a fasting blood sugar of 11, we require an X unit of insulin in a normal person. To maintain that fasting blood sugar 100, a insulin resistant patient will require 10 into X insulin, that is insulin resistance. Now, as I said, clinically it can be detected by finding out acanthosis nigricans. There are biochemical tests which can suggest insulin resistance. We diagnose diabetes on basis of glucose tolerance test, fasting more than 126, post 75 2 hours more than 200 is frank diabetes. If you want to do insulin resistance, find out insulin resistance, in the same glucose tolerance test, you measure fasting insulin and you measure post-glucose 75 gram insulin. If post-glucose 75 gram insulin is more than 100, the patient is likely to have insulin resistance. And it is severe if it is more than 300 MIU per ml. So this is one of the ways as looking at finding out insulin resistance biochemically. Now, this insulin resistance in skin causes acanthosis nigricans. Insulin resistance in the liver causes NASH. Insulin resistance at the level of ovaries causes PCOS, polycystic ovarian syndrome. High level of insulin stimulates IGF-1 receptors in the ovary, leads to thecal hypertrophy and leads to hyperandrogenism, secretion of androgens, testosterone, androstenedione from the ovaries, and leading to polycystic ovary syndrome in females. Similarly, IGF-1 receptor in the skin leads to epidermal overgrowth and acanthosis nigricans. So the bottom line is obesity leading to insulin, hyperinsulinemia, and insulin resistance at multiple organs manifesting in a different way. So baseline is obesity causing high levels of insulin, insulin resistance. Some of the genetic factors might add on it, because not only obese persons will have insulin resistance, sometimes the lean person will also have hyperinsulinemia and insulin resistance. For example, lipoatrophy or lipodystrophic patients, they have also insulin resistance, but they are lean and thin. Next slide. So what is the diagnosis of DM and NASH? As already has been spoken in a detail by Mukewar sir, the clinical features of obesity, investigations for diabetes, everybody is aware of GTT, glycosylated hemoglobin, lipid profile and anything. As the speakers have told about LFT, ultrasonography, MRI, MRI spectroscopy, fibroscan and other biopsy or other hepatitis markers. I learned a lot about fibroscan because we are yet to see fibroscan in a routine practice, their grading and everything. This was a new field for us, and I hope FibroScan will get its due position over a period of time. Next slide. So the treatment of diabetes and NASH goes hand in hand. It includes treatment for both. Weight reduction has been amply emphasized. As I said, diabetic diet, consultation with a dietitian is important. Low carbohydrate and low polyunsaturated fatty acids are important. Regular exercise is important. At least 40 minutes per day for at least 5 days. We have a smart mobile. In smart mobile, there is a health app. That health app tells you if you walk 4 kilometers, that is 6,000 steps. If you walk 6 kilometers, that is 10,000 steps. You should not sleep. At least you walk for 6,000 steps, that is 4 kilometers. This much of exercise will also reduce your insulin resistance, will help your weight loss. But dietary consultation and avoidance of typical high calorie food is also equally important. Insulin sensitizers. Low dose pioglitazone is used in NASH in a PVENS trial. In a tonic study in children, metformin was not useful as far as NAFLD is concerned. Vitamin E PVENS therapy, it has shown much beneficial results as compared to pioglitazone in PVENS study. Dr. Mukewar sir has already elaborated on this point. Dyslipidemias is a concurrent problem associated with obesity. Statins or ezetimibe are presently available for cholesterol. Fenofibrate and saroglitazole for triglycerides. Saroglitazole is a drug which is used in a diabetic dyslipidemia when triglycerides are more and we want to concentrate more on triglycerides. Triglycerides, as I said, in the hepatic hepatocytes more than 5% is hepatic steatosis. So reduce that is an Indian drug, but it has definitely shown beneficial results. We have heard Saurabh Mukewar, and we are going to hear Dr. Raj Gajbie for bariatric surgery. And ultimately, as I said, this type of cryptogenic cirrhosis can lead to end-stage liver disease, and then we have an answer in liver transplant. We will see much more liver transplant in such category of patients in future. As already spoken by a speaker, obeticholic acid is a furanolide X receptor agonist to be used by 25 milligram per day. Results are better with 25 than 10. It decreases steatosis. It decreases insulin resistance. It improves the serology, ALT, enzyme, GTT, alkaline phosphatase, and ASTs. It decreases triglyceride levels. It also have beneficial effect on histological changes in FLINT trial. We are awaiting the result of regenerate trial. It also causes weight reduction by 2 to 3 kgs. Hopefully, we are looking at a drug which can really reverse the changes of steatosis, maybe fibrosis, and in the long run will be beneficial. This drug is not approved in US FDA at present. It is being approved for biliary cirrhosis, but not for these indications. They are awaiting for the third phase 3 trials results, and probably they might accept this. But this drug has come in Indian market very recently, in fact, last month. So there is a limited, practically no experience with these drugs, but over a period of time, hopefully we'll gather some experience, and hopefully this drug will stay along with us for a long time. We really don't have any drug, to speak truth, that will treat NASH at present, and over a period of time, I think we'll be hearing more about obeticholic acid as a medical line of therapy for NASH. Next slide, please. So in nutshell, I would like to say NAFLD is associated with threefold increased risk of developing type 2 diabetes. Whereas patients with type 2 diabetes have higher prevalence of steatohepatitis, liver fibrosis, and end-stage disease. So obesity linked with type 2 diabetes will become a common cause of cirrhosis of liver. Individuals with NAFLD and type 2 are insulin resistant, not in the level of muscle and liver, but also in adipose tissue. In fact, American Diabetes Association in 2010 recommended universal screening for advanced fibrosis in all patients with pre-diabetes or type 2 diabetes with steatosis and elevated LT to identify and treat those at higher risk of development of fibrosis. We should be looking at this angle more commonly in the future. Next slide. In patients with type 2 diabetes and non-alcoholic fatty livers, obeticholic acid was in phase 2 and phase 3 clinical trials was well tolerated. It increased insulin sensitivity and in fact reduced markers of liver inflammation and fibrosis on some trials on histopathological basis as well. So we look forward to this drug in future for treatment of NAFLD. Next slide. I think I should stop this and I will request sir to forgive me because I have a family function to attend. My daughter is getting married. So please, thank you very much.
Well, wonderful talk on diabetes and the NASH by Dr. Ambulkar. And he has given us a very good pathogenetic insight into how the hormones and the cytokines work together in order to trigger insulin resistance. And it always initially remained in my mind as to whether diabetes causes fatty liver disease or fatty liver disease causes diabetes or insulin resistance causes diabetes and fatty liver disease. And now we know from his talk that it is the insulin resistance which causes diabetes as well as the fatty liver disease. And one would be interested, it is interesting to know that there are certain anti-diabetic drugs which have started working in patients with NASH and patients with NAFLD, because like say GLP-RA and even SGLT2 inhibitors. And but then at the moment, none of these drugs are accepted in practice. I congratulate Dr. Sunil for his wonderful talk. And there are going to be some question as to how, and it is also a job for the diabetologists, like the way they look at not only at the patient's blood sugar and the heart, whether there is a cardiovascular involvement, there is a renal involvement, there is a diabetic nephropathy. Now there is an additional job to look at even the liver as to what is happening in the liver and whether it is going to affect the patient's survival. Because of the involvement of liver. So let us get into the mode of doing fibroscans for every patient whose ultrasound shows that he has got a NAFLD. So go in for a fibroscan and find out whether he has any fibrosis, whether it is F1, F2, and should we go ahead with more intensive, vigorous treatment for that. Thank you very much, Dr. Ambulkar. I think, thank you very much. We go to the last lecture, should we?
Yeah. Before that, I have one question.
Well, the last lecture is going to be given by the person who calls the last shots. And he is no less than Dr. Raj Gajbhye, a highly acknowledged person, HOD, head of the department and professor of surgery, has a wonderful name as a teacher in the medical colleges. He has worked in GMC Nagpur, IGMC Nagpur, and he is an excellent laparoscopic surgeon. And he is going to give his views on bariatric surgery and how it is useful for patients of NASH. Dr. Raj Gajbhye, please go ahead.
Well, thank you,
Hello.
Dr. Deshmukh.
Audible? Hello. Yeah. Am I audible?
Yeah. Go ahead. Yeah. Go ahead, Dr. Kadu.
Wonderful.
Yes. Hello, sir. Namaskar.
You're audible. Go ahead. Shall I start with my talk? Okay.
Yes, you can start. I have only one question with Dr. Ambulkar only.
Okay.
One question. Simple question with Ambulkar. Where is he going to live? Or probably he has left? I don't know.
I think
Okay, sir, you start with your talk. I will ask him in person. Yeah, okay. Sir, you start with your talk.
Thank you so much, Dr. Deshmukh, for your kind introduction. And at the outset, let me thank Dr. Mukewar for inviting me to give this particular lecture. I'm not going to take much of your time. And he has told me about a month back that Midas Medical Foundation, along with API Vidarbha chapter, is going to have this symposium. Thank you, Dr. Mukewar, for inviting me, and thank you, Dr. Kadu and Dr. Deepti Chand for organizing such a wonderful webinar on this interesting topic, which is again very new to me also. So I'll start with my lecture. Is it visible there to everybody? Yeah, yeah. Okay. Please go ahead. My greetings to all of you from Government Medical College, Nagpur, and I will be giving a talk on role of bariatric surgery in NAFLD and NASH. That is what is the topic which was by Dr. Mukewar. He asked me to speak on this particular topic, and the scope of my talk will be it will be on impact of bariatric surgery on body weight and survival. I'll be discussing, highlighting some pathophysiological aspects of NASH and impact of bariatric surgery on hepatic steatosis, inflammation, ballooning, and fibrosis in NASH. Whereas some data to be shared on bariatric surgery in liver cirrhosis. So as far as the definition of non-alcoholic fatty liver disease remains to be, as Dr. Mukewar has already made my job very easier by elaborating on it. So there has to be an evidence of fatty accumulation in the liver by imaging, either by ultrasonography or by CT or by fibroscan or by imaging or by histology. The alcohol intake less than 21 and 14 drinks per week for men and women respectively, and there should be no cause. There should be no cause for secondary fat accumulation such as drugs, which Dr. Mukewar has already elaborated. The patient should not be on total parenteral nutrition, not starvating. There should be no starvation, and then the patient, we label them as to have the NAFLD. So what is the prevalence of NAFLD all over the world, and where do we stand? It is more than 30% of the population is having NAFLD in US, in Australia, in many parts of the Europe, and in India we stand. The incidence of NAFLD is more than 30%. So it's really a cause of worry to have NAFLD, and probably subsequently this is going to be a serious problem in our country. So as far as the population screening is concerned, the NAFLD is there from 15 to 29% of the patient, and if the patient has morbid obesity, then the incidence of NAFLD remains to be from 71 to 100%. Whereas in NASH, in population screening, it is almost 1.2%. And if the patient is obese, it increases to 25 to 50%. It is highest prevalence is there in 40 to 49 years of age. The male to female ratio remains to be almost equal. If the patient is having diabetes, then the chances of the patient having NAFLD is 50%. And if the patient is morbidly obese with diabetes, then NAFLD is 100% present in these patients. The prevalence of NASH is 50%, and the prevalence of cirrhosis in this patient remains to be 19%. So what happens to the progression of NAFLD? The normal liver with the increased lipogenesis, there occurs dyslipidemia, insulin resistance, obesity, metabolic syndrome, and type 2 diabetes, which leads to formation of NAFLD. And once the inflammation sets in, then lipid peroxidation, mitochondrial dysfunction occurs, oxidative stress, apoptosis, pro-inflammatory cytokinin activation leads to subsequently to NASH. And then with fibrosis settling down within the liver, there is advanced cell damage scarring, which leads to cirrhosis. As far as treatment of NASH is concerned, the hypothesis, the basic treatment of NASH remains to be weight loss. The hypothesis there is weight loss, and weight loss could be associated with improvement in liver fat accumulation, liver inflammation, and hepatic fibrosis. This is the effect of weight loss in NAFLD and NASH. And the basic treatment remains to be weight loss. The weight loss can be achieved by non-pharmacological methods and by drugs. The non-pharmacological methods remains to be lifestyle modification, a healthy diet, benefits of caffeine also can be discussed in can be a part of non-pharmacological methods. Pharmacological methods targeting specific inflammatory pathways, which has been aptly covered by Dr. Mukewar, and control of type 2 diabetes and hypertension, as has been said by Dr. Ambulkar. Then comes the surgical methods. Now, surgical methods has come in a big way as far as the weight loss is concerned. In obese patients, we do opt for bariatric surgery to have a rapid weight loss and a sustained weight loss in future. And this has been substantiated by the, as these papers were quoted by Dr. Mukewar and Saurabh also. So weight loss through lifestyle modification has significantly reduces features of non-alcoholic steatohepatitis. There is a nice paper in gastroenterology, which was published in 2015, which has shown that there is a resolution of steatohepatitis, there is improvement in NASH, the steatosis has improved before and after therapy. There is improvement in ballooning, lobular inflammation, and fibrosis status of the patients. What are the effects of bariatric surgery on body weight? Bariatric surgery provides effective long-term weight loss. As you can see here, with lifestyle modification and the conservative management for weight loss, they have not, at the end of 15 years, they have not have a significant weight loss. It's very difficult to have weight loss and to maintain it. But then approximately 4 to 5 kg of weight loss is there at the end of 15 years. Whereas the bariatric surgical procedures, you can see that especially in a gastric bypass, you can achieve approximately 35 to or more weight loss than that. And they can be sustained at the end of 15 years. Whereas with a vertical banded gastroplasty and banding, there occurs good weight loss, which can be sustained at the end of 15 years. So bariatric surgical, and this is published in the paper they have evaluated effects of bariatric surgery on mortality, which was published in New England Journal of Medicine. So what is the definition of bariatric surgery? Is a variety of surgical procedures which is being performed on obese subjects. It is done either by reducing the size and the capacity of the stomach. These procedures are called as restrictive procedures, or by resecting and rerouting the small intestine to a small gastric pouch. These are mainly malabsorptive procedure. We either by restriction or by creating malabsorption, we achieve weight loss in these particular procedures. And what procedures we have in our hand is gastric banding, but nowadays it is not in vogue due to foreign body which is present there. But then the sleeve gastrectomy remains to be one of the very popular procedure in achieving weight loss. Sleeve gastrectomy, we have gastric. Both these procedures are restrictive procedures, whereas we have this gastric bypass where a loop of the intestine is connected to a gastric pouch, and we have much more malabsorptive procedures such as duodenal switch. These are all strong malabsorptive procedures, but then they do achieve good weight loss and a sustained weight loss. So patients who, what's happening with bariatric surgery with to type 2 diabetes mellitus, a study published in New England Journal of Medicine, they concluded that patients who underwent bariatric surgery developed less type 2 diabetes mellitus, and there is a good resolution by many papers which have come up, which shows that the patients who are undergoing bariatric surgery, the diabetes is resolved for long term. What are the effects of bariatric surgery? As far as the survival is concerned, the survival after doing bariatric surgery in obese patients, the survival falls down to half. Almost, you can see here the survival in control patients about at the end of 16 years, the survival, the mortality rate is much more higher, whereas after the patients who have undergone bariatric surgery, at the end of 16 years, the mortality rate has certainly come down. So what are the effects of bariatric surgery? So how do the bariatric surgery causes the weight loss and the resolution of NAFLD? The bariatric surgery by vagal modulation, decreasing hypothalamic stimulation of lipid accumulation, decreases the obesity. It increases the beta oxidation and thus on dietary fats, and decreases lipogenesis, leading to improvement in lipotoxicity by decreasing peripheral lipolysis. It helps in decreasing the insulin resistance by increasing the insulin sensitivity. It decreases the inflammatory mediators, thus causing improvement in inflammation, and finally the resolution of NAFLD. It's all a complex mechanism by which bariatric surgery, by all these modules, act on resolution of NAFLD. And after bariatric surgery, there is resolution of NASH according to weight loss. If the weight loss is more than 10 kg per meter square, as Dr. Mukewar has also shown in his slide, there is 90.5% improvement in as far as the NASH is concerned, and the fibrosis improves from F0 to F1, F2, F3, and F4. And there is histological evaluation of NASH and fibrosis after bariatric surgery. There is, you can see significantly the fat cells deposition in the liver parenchyma. They certainly decrease, and is published in gastroenterology. There are certain studies which are published, and this is a study, a 5-year controlled longitudinal study by ASIO et al. Published in Annals of Surgery, where they have done 1,236 patients, and they were all biopsied, and they have compared Roux-en-Y gastric bypass versus adjustable gastric banding to reduce non-alcoholic fatty liver disease, and concluded that improvement superior for Roux-en-Y gastric bypass as compared to the lap band, and even with higher BMI patients. This is again a paper published in European Journal of Hepatology, which mentions that the mechanisms by which bariatric procedures may resolve NAFLD can help increase surgical approaches for metabolic hepatic dysfunction and also contribute toward developing the next generation of therapies aimed at reducing the burden of obesity associated liver disease. So this is the correlation of bariatric surgery with NAFLD, and this study has shown that they have used many procedures, RYGB, gastroplasty, and biliopancreatic diversion, and all these in all these procedures there is significant improvement in steatosis, inflammation, fibrosis, whereas there is improvement in liver enzymes of ALT, ALP, and there are improvement in lipid profiles also. So what is happening as far as the NASH is concerned? Bariatric surgery reduces features of non-alcoholic steatohepatitis in morbidly obese patients. And this study was published in 2015, where they have done 109 patients with proven NASH at baseline. And they have seen that distribution of NASH inflammatory activity before 1 year and after surgery. And you can see here that before and after, the inflammatory activity has, there is a significant improvement. And as far as the NASH before 1 year and after surgery, they have used the Wilkinson side rank test, and there is a significant improvement in these patients. There is significant improvement in hepatocellular ballooning, lobular inflammation, and the percentage of steatosis on liver biopsy from 60% it has come down to 10%, whereas the NAFLD activity before and after surgery it has improved significantly. These are all the various parameters they have used, whereas the ALT serum triglycerides at the end of 1 year and 5 years, there is significant improvement before surgery and after surgery. Bariatric surgery, what happens, what are the effects of bariatric surgery on fibrosis in patients with NASH? The fibrosis significantly improves. There's a study by Leslie G. et al. Published in Gastroenterology in 2015. And you can see here there is a significant improvement at the end of 1 year with bariatric surgeries as far as the fibrosis is concerned from F1 to F4. Impact of bariatric surgery, another paper, and they have concluded on this paper a weight loss of more than 10% of the total body weight loss predicted fibrosis regression. And these are various studies by various authors in the literature, where all the patients who have undergone for bariatric surgery, the steatosis has improved, resolved. There is improvement in resolution of steatosis and NAFLD, improvement in NAFLD score, and the transaminase levels have increased, and there is decreased prevalence from 45 to 31%. The various studies have quoted this. What's happening for bariatric surgery in cirrhosis? Can we go ahead with bariatric surgical procedures in patients of cirrhosis? And again, there is a paper which has come up with, which showed that patients undergoing bariatric surgery in compensated cirrhotic patients, and almost the number is approximately 4,000. They have also done bariatric procedures in decompensated cirrhosis, and in patients having no cirrhosis, and concluded that the mortality rate certainly increases in decompensated patients, that is 16.3%, and the mortality rate is higher. And bariatric surgery in patients with compensated cirrhosis, again, paper is there with where they have compared Roux-en-Y gastric bypass, sleeve gastrectomy, and lap band, and they have concluded that Roux-en-Y gastric bypass and sleeve gastrectomy is possible in child's A patients, and does provide an excellent weight loss. Again, another paper which concluded that laparoscopic sleeve gastrectomy is safe and effective in child's A criteria, whereas there is another paper they have done with the combined liver transplantation and gastric sleeve resection for patients with medically complicated obesity and end-stage liver disease, and they have concluded that gastric sleeve resection combined with liver transplantation it has no malabsorption, slower weight loss, and it remains to be technically easier. So the treatment in cirrhosis of liver for if the patient has NAFLD, NASH compensated cirrhosis, there has to be a goal to attain more than 10% of the body weight. One can consider laparoscopic sleeve gastrectomy if the patient has decompensated cirrhosis. If he is a transplant candidate, non-invasive attempt at weight loss should be done, and sleeve gastrectomy can be attempted in selected patients. We have a small experience at our center. We have done, since last 6 months, we have done a study of a prospective study of benefit of bariatric surgery on reduction and of percentage of steatohepatitis fibrosis in NAFLD NASH in a morbidly obese individual. And it involves a comparison of 2 liver biopsies taken intraoperatively and one taken post-operatively with a gap of 6 months. And a comparison is done between the 2 samples on the basis of the NASH score and NAFLD fibrosis score, and the quantification of the amount of NASH is done using one histopathological score and one biochemical based scoring system. So we have recently started this study, and you can see there is a significant improvement in pre-operative and post-operative weight and BMI of the patients. As far as the steatosis is concerned, there is a significant improvement of steatosis. The patients had 67%, in 67% of the patient had steatosis, whereas out of them, the 50% of the patients, the steatosis was resolved. As far as the lobular inflammation is concerned, the lobular inflammation has, there is 33% improvement as far as the lobular inflammation is concerned. Pre-operative ballooning, pre-operatively 33% of the patients had ballooning. There is no significant improvement as far as the post-operative ballooning is present, but then probably it will go up with time because it's a very recently we have started this study. These patients need to have a long follow-up. The NAFLD scores in our study, the pre-operative NAFLD score was approximately 7, and in patients after doing bariatric surgery post-operatively, the NAFLD score has significantly improved. Between the NASH scores, pre-op and post-op, you can see here the pre-operative NASH scores were higher, whereas the NASH scores post-operatively has certainly improved. This is the data which is collected. I will not go in these details. So to conclude, by improving obesity and diabetes, bariatric surgery reduces liver fat and is likely to reduce NASH progression. Prospective data have shown an improvement in all the histological lesions, including fibrosis. bariatric surgery leads to complete resolution of NAFLD in obese patients. However, randomized controlled trials are needed to further examine the therapeutic benefits of bariatric surgery for patients with NAFLD. Well, thank you very much for your patient hearing. I hand over the mic to Dr. Deshmukh.
Well, thank you, Dr. Raj Kashviye. This has been a very impressive talk on bariatric role of bariatric surgery in patients who are morbidly obese and they have NASH related problems, and it is one of the recommended surgery. Dr. Gajpie has focused lots of studies from the literature which have shown that there is a considerable weight loss which you can achieve, and as we had been discussing for the last 2 hours, that the weight loss is very important, and that can get you so much of an advantage in treating these patients as nothing else. And if that has to be achieved by whatever means, if it is not by pharmacological or a lifestyle means, then by bariatric surgery means, if you can achieve that weight loss, then you can do wonders in the improvement of these patients. There is a considerable biochemical improvement. There is a considerable histological improvement, and that is what he has shown by focusing various studies from the literature. And there is one wonderful study which I was trying to concentrate upon. That study is underway and he is working on that. It will be very interesting to find out as to what comes out through his studies, as to what happens to fibrosis in these patients post-operatively after several. And I'm still, that brings up one very important question as to after how much of a time when the weight loss is achieved, you start getting the results after 6 months, after 1 year, after 1.5 years, after 2 years. That is also something which will be very interesting to know about. And we'll be very keen to know as to what is the outcome of your studies. So thank you very much for enlightening us on bariatric surgery and its role in the management of NASH. I think it's time for question and answers.
Yes.
And if what is there in the bag, question bags, can somebody tell me about that?
Sir, I have got one question.
Okay.
Hello. See, we get a patient nowadays where they do ultrasonography unnecessarily where it is not indicated. And they report that they have got fatty liver grade 1. Then it's a very difficult scenario. What to do for those people? Those who are not having their enzymes are not raised and they are not non-alcoholics, but they are very much concerned that I have got grade 1 fatty liver.
Shrikant?
Yeah, I'll be happy to answer that. In fact, we have discussed this, that the fatty liver per se, without inflammation, is a fairly benign condition, but definitely associated with more risk to the life as compared to those who do not have it. It's not a totally benign condition, but fairly benign condition. You need to counsel the patients that if you are diabetic, control your diabetes. If you are overweight, reduce your weight. If you have lipids, control your lipids. Do work on diet, exercise. There is no need of drugs. Lifestyle modification. If you have sedentary habits, they should start doing exercise, work. In between, if he is a shopkeeper, ask him to have some steps in between and do exercise, find some time to do the exercise. I mean, this is all which is there, which one has to advise.
So achieve 5% weight loss.
Sir, Shrikant sir.
Yeah.
Those people, those who have got poor money, they don't have time to do exercise. They say, you tell us a drug which will reduce this fatty liver.
You have to tell them that there is no drug.
So I think this message should go on because everybody is asking for a drug. There is no drug for somebody is worrying.
Ma'am,
You
Shahid?
take existence.
So I have a point to make. Lifestyle modification is never going to go out of fashion. It is what is always required. The organ reserve always has to be there. Like we had this pandemic now. So about 60% of our patients were diabetics, were obese, were hypertensive, and the mortality was very high in these patients. So this is like catching it early and working on it before they actually land up into end stage issues.
Correct.
So awareness in the doctors itself is also very important. We start from the doctors and then it goes on to the public. So in fact, it's a very
I
like
don't think doctors, madam, doctors are not so much obese, most of them.
no, it's fine, but we have to be aware about the risks which are involved into it and work on it.
Let's say we do a lot of exercise. We
Yes, yes,
do a
of
practice
course,
as
of
well
course.
as
Yes,
exercise.
yes. It has to go on to the public as well. Yeah.
A word from Shahid. Are there any questions from the attendees? I would be very keen to find out. Shahid, please.
Yes, sir. Sir, there is one question from Dr. Shankar Khobagade, sir. What are the complications and contraindications to the bariatric surgery? This question is for Dr. Raj Gajbia, sir.
Yeah, I'll take upon this question. The contraindications for bariatric surgery remains to be the BMI. If the BMI is less than 30, the patient does not qualify for bariatric surgery. We have indications for bariatric surgery as 30 plus BMI of 30 plus at least 2 comorbidities, or if the patient has BMI of more than 35 without any comorbidities, we take these patients for bariatric surgeries. As far as age is concerned, yes, 2 old patients we do not take for bariatric surgeries, they do not qualify. But then we have even operated up to 70 years of age the patients of for bariatric surgeries who qualify for this surgery. Whereas if the patient is too much of comorbid to undergo surgery, not fit for anesthesia, these are all the contraindications for bariatric surgeries. But all of you even must have heard about Iman, who had a BMI of even 60 or 65, I do not remember exactly. She was 500 kg of weight, and even she was also operated upon. Having said that, it does have complications. The complications rate in experienced hand, it is less than 2%, 1.5 to 2%. But then if the complications occur, the complications are certainly dreadful and they should be identified very early. There can be complications such as leak. There can be, these are all immediate complications, post-operative complications. The patient can have reflux, the patient can have obstructions, the patient can have, the anastomotic site, obstruction at the anastomotic site. And the patients can have in long-term vitamins and mineral deficiencies. These are all the complications which are related to bariatric surgeries, but then they can be very well taken care of if you have a proper training in bariatric surgery, and if you keep the patients properly in your follow-up so as to avoid long-term complications such as vitamin and mineral deficiencies.
Sir, I got one more question.
Yeah.
One of my patient who is very VVIP here.
Yeah.
And his weight was 125 kgs.
Yes.
Who underwent the bariatric surgery.
Mm-hmm.
All of a sudden he developed intestinal perforation.
Yeah.
Where he at that time he was in Nagpur only.
Okay.
No two good hospitals admitted him. But otherwise, I have to manage him from this side. Ultimately, whatever things were done, we have to undone and redo whatever possible. Now again, he has gained the weight.
Yeah,
To
that
the
is.
extent because already he has got polio in both limbs, lower
Oh,
limb.
that was very
Deformity as
unfortunate.
well. And he has again gained weight of 115 kgs.
Yeah.
So he's all the time asking me what to do next.
Sir, it's very unfortunate for the patient developing such complications, but such complications do occur. I don't know after how many days or months the patient developed this complication. There
After
can
2 years,
be
sir. After 2 years.
after 2 years. So it seems to be some ulcer which has leaked at the anastomotic site, which has to be taken care by proper medication in the follow-up and of course, a proper endoscopy in follow-up. And if the patient has symptoms, he has to undergo endoscopy, see if there are anastomotic ulcerations. But these are all the known complications which occur in bariatric surgery, but they are all treatable. Now, once the complication are identified, they have aptly undone the things to save his life, and the patient is surviving. That is very good. But the patient has to have a weight regain after undoing all these surgeries.
He's asking for whether I should go again for
Yes, but
surgery.
then yes, he should
Will he go for bariatric surgery again?
bariatric surgery once again to lose the weight, and it should be done in an experienced and a proper procedure has to be selected for him. That is a very important thing.
Thank you, sir, and
Most welcome.
all the eminent speakers, the moderator, sir, Chan, madam, and everybody. Thank you very much.
One more question has been asked.
Wonderful webinar till today.
One more question has been asked. That is NASH progression to HCC without liver being cirrhotic. What will be the probable mechanism? This is the question for Dr. Mukewar, sir.
Well, it is known that deposition of the fat itself lead to inflammation, inflammation lead to fibrosis, and fibrosis is a precursor of malignancy. And we have seen this not only with NASH, but also with hepatitis B and C, where the inflammation fibrosis without cirrhosis can give rise to, development of SCC. So it is not uncommon to get hepatocellular carcinoma in patients without undergoing cirrhosis, merely by mechanism of chronic inflammation and some amount of fibrosis. So that is known. The secondly, about the Dr. Deshmukh's comment about bariatric surgery and when the histological improvement starts, I think the maximum improvement occurs at the end of 1 year. There are studies where the serial biopsies have been done at 1 year, 2 year, but the maximum improvement occurs in the first year of the life. Dr. Raj might also contribute to it, but then the subsequent beyond 1 year, the improvement is very slow. The maximum weight loss is also in the first year. So that answers the question.
That is true. And
last question. Though I am president, but still I am asking question. So Dr. S.N. Deshmukh will allow me to ask one more.
Please.
Huh?
Please go ahead.
Yeah. See the patients who are taking regular insulin. They have got a problem of, again, obesity. They eat more. Insulin has a property to gain weight. And then bariatric surgery is one option where the patient is almost, is cured of diabetes.
Yeah, I agree.
Right? So we have seen so many patients. So what is your opinion in such patients where the weight is more than 100 kgs and requiring more than 100 units of insulin?
Yes.
And is treated,
Yes,
they are not not getting controlled and getting putting weight. What will be your opinion regarding these patients, sir?
Yeah.
SBS, sir.
Yeah, I'll take on this question, and similar question has been asked by Dr. Shankar Khobragade also. That is what I can see. He is asking what is happening to diabetes after bariatric surgery. So let me tell you, friends, diabetes in most of there is resolution of diabetes in after bariatric surgery at the end of 1 year. And almost this resolution is approximately 80 to 90% of the patients are, the diabetes is resolved. Many of them are cured. And in fact, even I go up to saying up to this extent now that the indications of bariatric surgery, it has become more for metabolic surgery rather than bariatric surgery. And even the indications are now less and less BMI. People have now started doing bariatric surgeries for resolution of diabetes. Even they do not qualify. Say, for example, the patients who have a BMI less than 30, they do not qualify for bariatric surgery. But then, as far as the metabolic surgery is concerned, now they have started taking patients from 25 to 30 BMI, and it has been seen not only even we have published our study, but then there are n number of papers who have proved that there is a wonderful resolution of diabetes after doing bariatric surgeries, and now even it is being called as metabolic surgery.
Thank you, sir. Thank you very much.
Sir, I
Welcome,
have a
sir.
question to Gajvir sir.
Yes, please go ahead, madam.
Yeah, so this is a restrictive plus a malabsorptive surgery.
Yeah.
So how much is the malabsorption which you have observed, and is there a method of calculating that how much of the intestine is to be bypassed?
Yes.
According to the, so is there a procedure in which we calculate and do it?
As a president.
Hello, can you hear me, madam?
Yes, yes, I can hear you. Yes.
Okay. There are setup guidelines, and usually we use about 50%, 50 centimeters of the biliopancreatic limb, and we have about 150 centimeters of the absorptive limb. So yeah, so these are standard procedures in bariatric surgeries, but it is usually standard guidelines for bariatric surgeries, but many a times we do a tailor-made procedure for every patient. If the patient has a BMI, huge BMI of 50, more than 50, and the patient have multiple comorbidities, then we certainly increase the length of biliopancreatic limb, and so as to cause more malabsorption. Whereas these restrictive procedures are concerned, we certainly do some tight sleeves and some lax sleeves as the BMI of the patient and the associated comorbidities. So for each and every patient, we do not have a single procedure for all bariatric patients. We have, according to the BMI, according to the comorbidities, we have different procedures for different patients.
Dr. Ambulkar has left. Has this some studies been done on the incretin effects, how they affected after we cut the gut at different places?
Yeah, yeah.
The GIP and the GLP.
Yeah. There is. Yeah. Many studies are there. Many studies are there.
So the inherent synthesis of the hormones must be affected, no?
Yeah, and because of this, see how weight loss occurs in after bariatric surgery is absolutely a complex procedure. Probably the exact mechanism still nobody has understood. But finally, the observations are with bariatric surgery, it improves. It has too many changes in the alterations in the hormone levels, and there are too many mechanisms which are acting. But then whatever effects are there, the effects are beneficial. That is more important.
Okay. Yeah. Thank you, sir. Yeah.
Most welcome. Any other question?
Are there any questions?
Dipti, are there any questions there in the question box?
So it seems we have answered all of them. So, so we should be at the end of the program now. So I will propose a formal vote of thank all the luminaries. It was indeed a pleasure hearing. The Sunday evening was really very fruitful. Thank you so much, Dr. Mukewar sir, for conceiving the idea and going ahead with this program. It was in fact very good. And Dr. Thank you all the speakers. Saurabh was my student. I still remember he being posted with me in lectures and running away for his USMLE classes and all. So he is really groomed up into a very bright and very affectionate doctor. So congratulations to you, sir, for bringing up such a nice, bright son. Thank you, Dr. Gajbir sir. Dr. Ambulkar left now. So thank you, Deshmukh sir, for moderating this session, and NATCO for organizing this symposium. Thank you all very much. Hope we meet again sometime again with another program.
Yeah,
as this one. Yeah.
Thanks API and thanks NATCO and thanks Dr. Sharad Deshmukh and all the speakers.
Thank you.
Good night and good evening.
Thank you. Bye-bye. Good night.
It's my honor, actually. It's once again, it's just very good evening to everyone. And we have come to the end of this great informative session. So on the behalf of NATCO Pharma, I, Shahid, thanks to all the speakers, participants, moderators, and everyone who have related to this event.